Once stillbirth happens, delivery of the stillbirth is a big problem. The timing and mode of delivery of stillbirth should be determined by gestational age, patient preferences, and clinical examination. Here I wish to tell each and every gynecologist, as Secretary General of Delhi Gynecologist Forum, that there is no medical urgency for immediate delivery. There is absolutely no medical emergency or urgency for immediate delivery. And for some women, expectant management or delayed delivery may be desirable. You'll ask me that there is a risk of consumptive coagulopathy. Consumptive coagulopathy and intrauterine infection are rarely associated with prolonged expected management. Between 80 and 90% of women will enter spontaneous labor within 2 weeks of fetal death. However, the latency period may be substantially longer. Retention of dead fetus can cause chronic consumptive coagulopathy, but usually it occurs after 4 weeks and is quite rare, very rare. Another disadvantage of expectant management is that the long interval between the fetal death and a spontaneous labor limits the amount of information can be obtained regarding the cause of death from a post-mortem examination of the infant. Therefore, sometime in second trimester, people decide about labor induction and dilatation and evacuation. The results are the same in expert hands. Therefore, the mode of delivery should be based on patient's wishes as long as the provider experience and the gestational age allows dilatation and evacuation to be viable option. For induction of labor, at less than 28 weeks gestation, misoprostol is the most efficient method of induction, regardless of Bishop score. Although high dosage oxytocin infusion is an acceptable alternative, after 28 weeks of gestation, drugs such as oxytocin and prostaglandin administered for induction of labor can be according to the standard obstetrical protocols. If there is a previous uterine scar and the gestation is less than 28 weeks, the low segment scar is transverse, the usual protocol of misoprostol induction at less than 28 weeks can be used. If it is more than 28 weeks with the previous scar, the oxytocin protocol may be used and the cervical ripening with Foley's catheter can be considered. Labor induction resulted in vaginal delivery occurs in good 98 to 99% of women without previous cesarean delivery. Women with a history of prior cesarean delivery, the vaginal delivery rate is 90 to 92%. The risk of 1 to 12% of uterine rupture with labor can be there in case proper protocol is not used and proper supervision is not done. Hope you will take the delivery after stillbirth seriously and offer the best with close supervision to your patient.